Hi, everyone. Thank you for joining us for the first session of the How to Build a POCUS program webinar series. My name is Kara Beth Carr. I am a third-year neonatology fellow at UH Rainbows and Children's Hospital, and I am the fellow moderator for today's session. Dr. Karina Lawrence from UPMC Children's Hospital Pittsburgh is our lead faculty moderator. Please enter all questions that you have throughout the webinar into the chat, preferably to myself, Allison Payne, Rachel Weinstein, or Karina Lawrence. If you can, or really any of the co-hosts is okay. We'll be constantly monitoring the chat for any ongoing questions, so that way we can then ask those questions to the panel at the end of the session. And now I am honored to introduce Dr. Maki Fraga as today's speaker. Dr. Fraga is an attending neonatologist at Children's Hospital of Philadelphia and an associate professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She is the medical director for the neonatal point-of-care ultrasound program at CHOP and also helped develop the annual CHOP ultrasound workshop. In addition to point-of-care ultrasound, she has a specific research interest in neonatal hemodynamics, and she has published numerous papers on these topics. I will now turn it over to Dr. Fraga, who's going to talk about program development.
All right, so good afternoon, everyone. Thank you, Karabeth, for that kind of introduction, and thank you, Karina and both Karabeth, for leading this effort. And of course, thank you to all of you who are on the other side of the screen. I mean, there's so many people that have joined today, and this really tells us the national interest around point-of-care ultrasound. So thank you, Patrick, to giving us this space. So this is the first conference of this educational series around point-of-care ultrasound. So what I'm going to be talking today in this first conference is about building a strong foundations, really towards point-of-care ultrasound program development. I'm going to be sharing mainly my experience on CHOP and how we did it. So I can just really give you examples on how to build these kind of programs. I'm going to try to take 30 minutes and then leave a lot of time for the panel of experts that we have who are wonderful, and I would like to have time to answer questions. So I have no disclosures. For the next 30 minutes, the objectives are we're going to be discussing the benefits and the challenges of adopting ultrasound in clinical practice. I'm going to be highlighting the importance of understanding the context in planning ultrasound integration. And then we'll be describing why individuals training in ultrasound around the world, doesn't matter where you are from, would benefit from external support. Okay. So first of all, I would like to start defining what point-of-care ultrasound is. So we understand as point-of-care ultrasound when ultrasound is used as a clinical tool to integrate history and clinical examination findings with real-time and focused sonographic assessment to answer a very specific yes or no clinical question. That's very important. So it must be goal-directed and problem-oriented. It must be performed at the point of care by the clinician. Again, to answer a specific question, has to be interpreted, of course, in the clinical context, has to be short in duration, reproducible, and an adjunct to physical exam. But, you know, ultrasound doesn't just stand alone, right? So we have to integrate it in what we do in clinical practice. So I put this slide because it really tells the story of what we do on a day-to-day basis. So, you know, we take people, we take processes, and we take the technology available. And then we integrate them in the ideals of care that have been determined by the Institute of Medicine. And those are timeliness, patient-centeredness, effectiveness, safety, equity, and efficiency. So when we bundle all these together, they are supposed to give us good outcomes, right? But not only for patients, but also for providers and for institutions. And the reality, and I'm sure you all agree with this, is that ultrasound has now blended so much into our clinical practice that we have already moved away from using the stethoscope, and we are much more using ultrasound probes, right? And I always say that I think they have become the new addition of the 21st century doctor's bag. And definitely the upcoming generations, right, graduating from medical school and the ones that are graduating at the moment are trained to view ultrasound as we were trained probably to view a stethoscope. So, okay, there we go. So now we have given really ultrasound a new application, but we can't truly say that ultrasound is new, right? Because it's been around for so many years. But as clinicians are making off point of care ultrasound, I would say, new clinical applications. So how do we assess this? Well, if we look at business, they usually use a formal checklist about what type of things they should be looking at before deciding, to invest in it or not. There are several questions that they ask in this checklist. So they ask, is this a radical departure or an improvement on existing practice? One of many potential solutions, or does it just stand alone? Is the technology complex or self-evident? Could you add your own ideas? What are the important benefits and performance measures? What's the data to it, right? And are there any incidental findings likely? And really, we can make an argument that ultrasound is a pretty radical departure from what we typically do as clinicians. We can actually, visualize, look into what's going on in real time at the bedside of our patients. It really does stand alone. We haven't seen anything like this, right? It's really self-evident, and the answers are, of course, pretty obvious. We can add our own ideas to it. We can also take ultrasound away from the NICU or from critical care and put it in any other discipline. And they really can modify their approaches to clinical diseases, right? While they are seeing it in real time. There are incidental benefits, and it should, benefit really our patients. But also, it should benefit our educational processes by truly understanding more of the underlying pathophysiology of our patients' diseases, and by bringing this understanding much closer to us, right? So there are really some emerging realizations. We know that the number of gaps in our knowledge of basic pathophysiology is really substantial, right? And we know that ultrasound can help identifying pathology, characterizing disease processes, making clinical decisions, and potentially and hopefully improving patient outcomes. So in other words, what we are doing, we have been doing for the last years, we are trying to teach a much more modern and much more integrated approach to target therapies. So we're trying to move away from the use of pre-written protocols or algorithms that we used to carry in our back pocket all the time in the NICU, and move towards a more kind of precision medicine, putting this kind of puzzle right together case by case. So the question we always ask is, why not to take a look? And really this slide summarizes why the use of point of care ultrasound is so clinically relevant. So in this slide, I present 3 different patients that presented phenotypically in the same way. They presented in shock with the same clinical findings, same vital signs, but totally different underlying pathophysiology. So for those of you who are not familiar with echocardiograms, these are all 3 parasternal short axis view. So the top left corner shows hyperdynamic ventricles with near complete collapse of the left ventricle in systole due to hypovolemia. The middle clip is showing a severely dilated right ventricle with severely diminished RV function and bowing of the interventricular septum. This is due to pulmonary hypertension. And lastly, the clip on the top right is showing severe decreased LV function. So we really want to have this information available at the bedside, right, as soon as possible, because this way we can really target treatments, which in these 3 different patients are completely different, right? So if we can get a probe on quickly and look quickly at the heart, only just by getting this one view, we can come up to many, many conclusions. So we really want to establish a goal-directed therapy. But what about the performance measures, right? What about the data? And this is what we know the data tell us. We know that there is a steep learning curve to ultrasound, to learning ultrasound, meaning that we can really teach a lot of people in a very short period of time how to answer very focused yes or no clinical questions reliably. There is greater accuracy of ultrasound data than many of the gold standards that we use for clinical assessment at the bedside right now. There is definitely more rapid time to diagnosis. We get new information that is not available through the clinical exam, through any labs values, through monitoring, that really changes our management. And there is data coming out saying that hopefully and probably looks like it also improves patient outcomes. So the most important question now is why, if data support the use of point of care ultrasound, why is it not widely used across pediatric disciplines? So if data really favors its use, why is not being used everywhere? There has to be a reason, right? And there must be something that is holding it back. I guess there is. So before getting into that, let me give you some data about how frequently point of care ultrasound is used across different disciplines in pediatrics. So we know that here in the US, and this is information that has been collected through surveys, 96% of the pediatric emergency departments and 90% of PICUs have access to bedside ultrasound. However, as you can see, roughly half of them have any sort of formal training at their institutions. Most places still do not have formal training. So what's happening to neonatology? So unfortunately, and I know we are all fully aware that we are far behind, this survey was sent to all PICU and NICU fellowship directors and showed that critical care, as you can see, has far more access to ultrasound machines when compared to the NICU. That 76% of critical care physicians use bedside ultrasound for diagnosis, whereas you can see only 29% of neonatologists do. As far as use of ultrasound for procedural guidance, 95% of PICU use ultrasound to guide central line placement, for example, is now considered standard of care, compared to 37% of NICUs, and still very few neonatology fellows are receiving some sort of training. So we really need to catch up, and this is why we came up with this series of conferences. And why do we need to catch up? Because we know that point of care ultrasound education has already been incorporated in medical school, right? It's part of their curriculums already. So the use of ultrasound as an extension of the physical exam already, I think, represents a transformative change for medical training. So this is a Canadian cross-sectional survey-based study that reported back in 2016 that of the 17 accredited schools in Canada, half of them have integrated bedside ultrasound teaching in their undergrad curriculums. Whereas in the US at that time, and now is far more than that, 60% of the medical schools have already bedside ultrasound teaching in medical school. So we truly need to push this field forward. But how do we do this, right? And that's the main question. So we have to be very thoughtful, first of all, on how to educate people in its use, and how, most importantly, how we can safely translate these into clinical practice. So where can we start? So this is easy. We need to start training people. This is the beginning point, right? Train people. So I can say that at CHOP, probably we have taught thousands of people throughout all the courses that we offer twice a year, but not only at CHOP, but also in other places in the US, Canada. We also give courses in Switzerland. We have gone to the UAE to give these courses everywhere. So, and this is not published data, but we know that when we do these 2-day courses, that really is it's really an overview of all the ultrasound applications, right? Like we just don't go deep anywhere. It's just we present all the core applications and we just give talks on, and we try to teach whatever we try to teach. We know that after this 2-day course, the uptake is not going to be that great. So that probably in all these diagnostic, procedural is different. Procedural people, are using it much more frequently. But in the diagnostic applications for point of care ultrasound, maybe less than 10%, as you can see in this graph, of the people that we train are going to take this back to their home institution and perform this at the bedside, right? So it really doesn't seem to be that straightforward. But the question is implementation of ultrasound or ultrasound programs straightforward? We actually the answer, this will surprise you, is yes. And why do I say yes? Yes, I say yes because this has already been done. We are not coming up with anything new. So many years ago, the American College of Emergency Physicians, right, came up in 2001. It's been over 20 years, published emergency medicine ultrasound guidelines already. And at the same time, 2001, the ACGME mandated that emergency medicine residents graduate with competency in point of care ultrasound. So this policy statement that I'm showing here really describe the need for a formal system in place. It describes everything, the identification of physician ultrasound leaders, concomitant development of formal training, institutional credentialing, and a quality assurance process as well. So this way we could, of course, protect patients, providers, and institutions. So this started, as I said, in the adult world back in 2001. By 2015, it got into pediatrics by the emergency department, who then, they published a policy statement that was endorsed by the American Academy of Pediatrics already, right, on the use of point of care ultrasound by pediatric emergency physicians, not only for procedural guidance, but also as a diagnostic tool to expedite decision making and to direct follow-up diagnostic imaging appropriately. So it's been all done for us, right? They even develop formal curriculums for training curriculums for their fellows. So our solution, local solution at CHOP, was really simply take everything that was already done, meaning take the core applications that were already developed by the ACIP and really adapt them to the pediatric core applications. So we kind of did this together between emergency and medicine, critical care, and the NICU. So we thought about what are the different pathologies that are frequently encountered, first of all, that are amenable to ultrasound, and importantly, that have discrete outcomes, right? Like yes or no, present or absent, mild or severe. And then after we identify those, we developed learning objectives. So we mainly divided point of care ultrasound into two big categories, into diagnostic point of care ultrasound and procedural point of care ultrasound. So procedures, that we do as critical care physicians, neonatologists, we're all trained to do this, right, within our fellowship program. So really using ultrasound or adding ultrasound to our procedures is really an adjunct technology that we use to actually improve our performance and to improve patient safety. So, this is the easiest way of introducing point of care ultrasound in any unit because we are already credentialed to the procedure. So we are just adding the technology to help ourselves. And you can consider yourself already, credentialed for this. But diagnostic ultrasound is different. So first of all, because it's totally different and new to us clinicians, right? This is something that we have not done before. And really is helping us to make a diagnosis to help guide our therapies. So how to implement this is the question, and this is the most difficult one, right? So when we expand to diagnostic ultrasound, we are approaching, as you know, other departments. So we are approaching radiologists, we are approaching cardiologists, and we acknowledge that probably there is an overlap with their specialties, and they may not be, supportive of this practice. And I know many of you find this barrier actually in your own hospitals. But when defining our domains, it's very important to clearly communicate our goals. So, and why is that? So when we present point of care ultrasound, we really don't say that we are doing point of care ultrasound because we can do it, because it's easy, we have the machines there. We don't say that. We really explain that ultrasound is really helping us guide clinical decisions, and we show examples and really helps us direct patient care, and it helps us target treatment, and it helps us immensely in urgent situations, right? When we have to take a look right away, we can't wait for a radiology or a tech to come to the bedside. So really we are doing ultrasound because we should do it, because this is helping us to understand better what's happening with our patients. And really that honestly brings people together to a common goal that ultimately will be, and it is, to improve patient care. So our institution, or the institutional bedside ultrasound program at CHOP, started early in the 2000s. So the story was that it started through emergency medicine with Aaron Chen and critical care Akira Nishizaki. And we were very lucky to have all these multidisciplinary leaders at CHOP that really understood at that time that this was happening everywhere. So in Europe, there was a lot of point of care ultrasound being done. In Australia, there was a lot. And I do remember we had at that time, all these key people. These people were the division chief of critical care. This was the division chief of cardiology. This is the department chair of pediatrics. This was at that time the department chair of radiology, and this was the chief of ultrasound. And Meryl Cohen at that time, Phyllis was my chief in the NICU, and Dave Manson, the medical director, who were very supportive of these. And Meryl Cohen at that time, she was the chief of the Echo Lab. And I remember, she told us, I know this is happening, we can't stop this. So we better help you guys to do this right. This is what we need to do. And I thought that was not only immensely helpful, but very smart. So all these multidisciplinary leaders came together to really mutually agree on a structure for implementation. And this was the most important thing. So we came up with the core applications in the NICU, in the PICU, in emergency medicine. So we blended this with didactic and experiential learning, and all these process culminated in a credentialing process. I don't want to go too much into this because we will have another talk describing the process, but we did come up with this structure that also has a QA process, which is a must, right? With documentation and image storage and all that, really to protect ourselves, the institutions and our patients. So really the result is that now, after we all came together, we have a big program everywhere. And the result is that Dr. Samir Kaplan, who is a radiologist, was or has been appointed a couple of years ago as the point of care ultrasound supervisor for the whole hospital. So, we have leaders in each department or division, critical care, emergency medicine, me in neonatology, anesthesia, general pediatrics. And from here, the team just keeps growing exponentially. Like every year we add more and more and more people that do point of care ultrasound. So really we've got good results working together. And this is the key, right? Is working together. Now our ultrasound curriculum is really embedded within the fellowship program. We of course would like to standardize this across the country, but this is where we started. We do have a system for documentation, image storage, a QA process. All these ended up in publications of results supporting translation of education to clinical practice. And there has been a much extensive diffusion, I would say, beyond critical care, neonatology, and emergency medicine. So right now at CHOP, these are all the divisions that are using point of care ultrasound, and they have machines and they have people competent on this use and this technology. So really, it is everywhere. So across CHOP, you can see these machines everywhere. And the point of care ultrasound director, who is the radiologist Samir Kaplan, really has 8 different areas of governance, and we have this structure where she has to really take care of education, privileging, QA, purchasing, all the things you can see here. And we have been working on each of them within this multidisciplinary team. And as I said, you can see these ultrasound machines everywhere at CHOP. I'm sure all of you have these questions. What ultrasound machines should we get to start a program? That's the easy one. Everyone will have different opinions. My opinion is that you need something that is portable, that is light, that you can carry around the NICU. Different brands all are great, but they're like this kind of laptop thing. And what pros, I think if you're starting the program, you need a linear probe for vascular access and lung ultrasound, and you can use a phased array, not only for the heart, but you can get away with the abdomen and the head using a phased array. So, if you have 2 probes and an ultrasound machine, it's a great start. So, but that was happening at CHOP. So what's happening elsewhere? So this is again critical care because they're a little bit ahead of us. And this was published by Thomas Condon, my friend from the PQ at CHOP. So he sent a survey 4 years ago now to all the PQ programs. And as you can see, over half of the programs are performing diagnostic ultrasound studies. I mean, procedural, again, is different. Almost everyone in the PQ does it. But as you can see, less than 10% have a credentialing process. 1/4 of them has some image storage organization, 20% documentation, and 18% a quality assurance process. So you see, this is the structure, the infrastructure for the program is really lacking. But the conclusions are that, and this is the truth, that studies are being performed despite inadequate infrastructures, and that few institutions, very few, have credentialing process, and even fewer have many providers attaining this threshold. So, so what we suggest is just share solutions to our shared problems, right? Because we all have the same challenges. So if we can share solutions, we can overcome this, right? So this is it, let's work together. And this is what we have been doing with my team at CHOP. We have been networking and working with many other institutions. Everything was growing up until COVID came. And our courses, of course, were all shut down. We couldn't do any more courses, but still, you know, we felt that people were still seeking for educational opportunities. So, you know, this was a little bit surprising. We got together and said, what are we going to do now? We're going to offer how many years? We're not going to be able to offer a course or get together again to do these hands-on sessions. And I said, well, why don't we offer a virtual course? Like we thought, like, this is ridiculous, right? Well, okay, well, let's give it a try. So I said, well, let's offer this. And here we were, like, it was Thomas and I sitting for like 3 straight days in a room, like with socially distant. And when we offer it, within the first week and 2 weeks, we got over 500 faculty and learners from all over the world, right? Like, this is how the representation from the world was. So really, this tells you, you know, that the widespread interest in point of care ultrasound. So, so you know, we do offer courses at CHOP. We have courses in Switzerland. We have been to China. Akira goes to Japan and gives these courses all the time, and also the Middle East. So really, let's just work together. We have a shared community, and really our needs are not so different. Our patients are not so different. We are working with the European Society of Pediatric and Neonatal Intensive Care. We are part of the point of care ultrasound program. We now, I'm very happy to say that we have partnered with Stanford. So Shasya is on the line. We can talk about that. We are going to be offering 1 course a year at Stanford. We are now working with Alan Groves to partner with him and start other courses in Texas. So, you know, it's just getting together and work together will make this easier for everyone. But you know, after saying all this, I have to say, and I always acknowledge this, that there is potential for system failure, and we need to recognize that, right? So we need to recognize that not all information is good information. And I know that the risk of misdiagnosing is high when diagnostic ultrasound is used by inexperienced practitioners. So again, we have to be very careful, and we have to translate this safely into clinical practice. You know, there's also may lead to additional and unnecessary testing, you know, false positive, or may provide unwarranted reassurance in cases of false negative. So we have to be very careful. With all this, there is a fear factor that comes along, but Dr. Shahab Nouri likely looked into this some years ago, and this study suggested that, at least in neonatology, there was no lawsuits against neonatologists due to point of care ultrasound. So I would say that for now, it's more a perceived factor than a real one. But in fact, also I would say there is some literature reporting that there is increased risk of litigations in situations where an ultrasound machine actually was available and was not used. And the typical example for that is, you know, someone sticking a needle in a peritoneal sac blindly when there was an ultrasound machine. So have to be careful with that as well. Anyway, so to conclude now, because I want to leave time for our panel, I want to say that bedside ultrasound can answer, of course, commonly encountered clinical questions following focus training and experience. Individual ultrasound skill development requires support. Where we seek to improve care to patients, we really can often find novel solutions through shared experiences, resources, technologies, and knowledge. So really success depends upon collaboration. And again, by working together, we can deliver improved care to pediatric patients around the world. So I thank you so much for this time. And I think I was, right on like 30-minute mark. We are gonna now have some time for the panel. I think Carabeth is gonna introduce everyone.
Yes, thank you so much, Dr. Fraga. We are now going to move into our Q&A session with our expert panel. So our panel does consist of Dr. Karina Lawrence from UPMC Children's Hospital, Pittsburgh, Dr. Sai Muksapuram from Cincinnati Children's Hospital, Dr. Shazia Bumble from Children's Hospital Atlanta from Emory University, Dr. Maki Fraga from Children's Hospital of Philadelphia, Dr. Stephanie Marshall from Lurie Children's Hospital, Northwestern University, and Dr. Alan Groves from Dell Children's Hospital, University of Texas at Austin. So we will get started with some of our questions. And Maki, if you can unshare your screen, and that way everyone can see all of we'll see the panel at once. Perfect. So the first question that we want to start with are, who are the key members to have on your team? So who are the key stakeholders?
Okay, who wants to talk? There is Alan. I can see Alan.
I normally get accused of talking far too much, but I'm happy to be offered the opportunity to talk first. Thanks so much, Maki. Thanks, Patrick. Yeah, there are lots of key people in that. And if you go, I think Maki's slides will be available offline. You can see that she's beautifully put together for you the different components in this structure. And the structure for this POCUS is key. The reason why the cardiologists lose some sleep over neonatologists picking up the probe and scanning babies is that if we do it in a non-structured way, if we do it without some checks and balances in place, we do add risk. But as Maki said in her penultimate slide, I think most of us in this panel would agree that the risk to patients now is in not adopting POCUS rather than adopting POCUS. So I think you need a person who is driving your, I think you need somebody to develop your list of indications, your training process, your credentialing process, your image storage, your image review. I think it's extremely important to have a friendly, helpful cardiologist working for you for any indication that's looking at the heart. I think it's also nice to politely tell them that if I'm just looking at the heart to see whether the UVC is in the heart or not, that I don't need their help, but thank you so much for the offer. There's some delineation of areas of control here. I think the radiologists are super valuable for the brain and liver imaging, for example. I really like a simulation person for this. There's 2 or 3 different simulation tools that are available for neonatal point of care ultrasound. They're tremendous learning skills. So I think that's my key 8 people. Again, if we go back to Maki's slide, I think it was 2 from the end. I probably have it here that I can pull up because I've stolen it to put on one of my own presentations. Is the idea that we have each of those 8 key elements that she pointed out within the governance of her overall POCUS czar.
Yeah, I agree with Alan, and Maki did such a nice job outlining and also outlining all the people that were involved. And for us, when we started at Stanford, that we didn't have much experience in the NICU, and so partnering with others who had a lot more experience was really useful. So we've had a good partnership with the PICU. Here at Emory, we actually just finished up a scanning session with one of the ED docs who's really great, who's been a good resource here. So safety in numbers and experience has been really useful. So reaching out and finding out who within your hospitals are already doing ultrasound. It also helps from that standpoint to know what are the mechanisms and archiving systems and what's already in place. And we'll get to that more later on. But But yeah, the more people that you can seek out to help and see that we're trying to help patients overall can be really useful for program development.
Yeah, I just agree with everything, and just wanted to add one more thing, that if someone has experience working with the medical staff office, especially with the credentialing department, if they've gone through that, having them on your team will help that process smoothen and go through much faster, as that's one of the more challenging aspects as well.
And to echo what both Alan and Shazia have said in terms of safety and numbers, definitely if you have somebody at your institution who has been there, done that, they are a wealth of resource. For me, it was somebody in our pediatric emergency department. So she was able to help hold my hand through the process and ultimately became our POCUS director for our institution. So certainly if you have somebody that can mentor you through that process, that's wonderful. And especially if you're really just starting to get your program off the ground and even thinking about buying equipment or upgrading your equipment, having somebody that knows your supply chain. This person is probably going to be in your radiology department, but making sure that you order within, you know, the fleet, the brand that your institution typically orders with, because they tend to have contracts and they tend to have service plans. So ordering within your fleet that your institution already has can definitely be a bonus.
I wanted to jump on to that. I think this working together message that Mackie's pushing so brilliantly is so true. And I'm so happy to be part of a neonatal and pediatric specialty where we want to collaborate with each other, not compete with each other. One of the things that Dr. Lawrence is putting together is will be a fellowship-wide curriculum and syllabus for learning. But I think a big part of that should be a hub where we share our documents and guidelines. So for example, I've written here for our use here in Austin, a kind of standard operating procedure for our indications, the training, the general principles, how we do our assessment of image efficacy, doing a mini review for each individual's ability to get the images, standard forms for quality assurance, and so on and so forth. We've got a document on how we, are for procedural ultrasound, an SOP for that. With 800 NICUs nationwide in the US and so many other worldwide, there's no reason for each place to write their own document for that. We should and are copying and pasting from each other and making that as efficient, as effective as we can. And I don't think any of us want to hang on to our protocols so that we're better than the hospital next door. I think we all want to have those all in one place so that everybody can build on them.
Building on that question a little bit, there was a specific question. We don't have a POCUS program in the Peds Critical Care Department, but we do have an active POCUS program with the adult side. Can collaborating with adult teams be helpful? Everybody's nodding.
Yes.
Absolutely. That's your beginning then, right? Like you just stick with people who are doing it. Doesn't matter if it is in the adult world, and then you can translate it and bring it into pediatrics.
Yeah, and depending what hospital system you have, we started looking with adult ED because they had the QPAS system. So we looked to see how they rolled it out, how they had their hospital set it, how that portion of the hospital set it up, to see if we can use it on our side as well.
Yeah,
I think
even if,
sorry, Sai, go far away.
Oh, I was just going to add that even if there's no department that already has an established POCUS program, just reaching out to other places which have established programs and collaborating with outside of the institution and trying to find out what the easiest way to approach would be another way as well.
I just wanted to add, I think we all feel some pressure when we set up a new program that we're setting up this all-encompassing one program to rule them all. And that's not how things change in healthcare practices. They start much more iteratively than that. So I think it's a very good idea to start with one area, and that one area should be the area closest to where you have that existing support. So if you've got an adult practice that is using this for arterial line insertion, maybe you start using it for arterial line insertion first on your NICU. The single thing I'm most excited about from POCUS in the last 10 years is Ben Koziak's paper that I've just shared on the screen here, that many of the people on this panel are co-authors on. This is Ben showing us that when a UVC gets stuck in the liver, we can use ultrasound to guide it back into the umbilical recess and then guide it through successfully into the heart. Very, very, important, pragmatic thing to do. It's a very reasonable to start with just POCUS for PICC lines or POCUS for UVCs. I really like Mackie's delineation here of procedural versus diagnostic, because procedural, it's so easy to tack that onto what we're already doing. And I don't have to ask anybody else's permission outside the NICU to do that. But yes, if I'm looking for any signs that could be linked to structural congenital heart disease or other circulatory, that there is more risk with that. So I think start procedural and start one link to the side of whoever it is you're going to be working with.
Great, thank you. And moving a little bit to the equipment side of things. So we have gotten several questions about equipment. So if I only have so much money, what should I prioritize in equipment first? And kind of a subset question of that, are there any good handheld devices that can be used in the NICU?
I can add one quick thing before going to the devices. When we started, we actually didn't really have the funds to get a machine. So we asked around and said if any other divisions had machines that we could utilize. So cardiology actually had a couple that we were able to use. So that's just a consideration for if while you're waiting funds, we had something, we didn't have a linear probe, we at least had a phaser and could start doing some things. So that's how we kind of started initially.
Yeah, so and I would say, like if you have some money, right? Like the competition between all these industries have gone, like it's been like growing so much that the prices surprisingly have come down in the past years. So like for portable, machines, it depends on what you're buying, what brand you're buying, but it can really oscillate from, someone is asking about the price, from $30,000 to like $60,000. But around 30, you can get a machine. And on top of that, you have to add the probes, and the probes are expensive, usually, like 7,000, something around that. I personally don't have any handheld device, so I can't speak to that. I know the Butterfly, the probe has a very big footprint for neonates, so that's why it doesn't work for the NICU, but I don't have experience with the Vscan. I don't know if you guys, yeah, Alan does.
Yeah, so we're in the process of upgrading all of our machines here in Austin. So I've just trialed 6 or 7 types of machines in the last 3 weeks. I'm promising myself I'll do an update page on our NICU POCUS website to talk about each of the different machines. Broadly speaking, you can get a handheld machine for $5,000 or thereabouts. The GE Vscan Air is my personal favorite, but I don't work for GE, I promise. It's less than $5,000. It is a reasonably small footprint. It links wirelessly to any Apple or Samsung device. We have 2 of those on order, and I think they're fantastic devices with a linear probe for defined indications. So I now, whenever I am on call in the NICU, I have my handheld device with me at all times. If I'm called to a code, I'm bringing my handheld ultrasound probe down with me, because if you've got a code and you're not sure what the heart rate is, point-of-care ultrasound is a fantastic way to genuinely know the heart rate. That's getting into standard of care territory for me, and there's nice data on that this year about that. So a standard handheld for 5,000 can certainly show you heart rate. It could rule out significant pericardial effusion in a code, significant pleural effusion. You can use them pretty much to find PICCs and umbilical lines centrally. You can't do much cardiac function assessment with them. You can't do much peripheral IV placement with them. For that, I think you need to get into the 30 to 60,000 market. We happen to have just decided to buy the GE Venue, but again, I promise I don't work for GE and I'm not getting a discount from them, but it has a perfect, so as Mackie said, you need two probes. You need a linear probe for peripheral and a sector probe for cardiac. The sector probe can peek between the lungs to see the heart. The linear probe gives you much more linear detail so long as you've got a good imaging window. So you need one of each probe with those machines. For between 30 and 60,000, from GE, Philips, Mindray, Siemens, all are in the same kind of area, and it's worth getting your rep to come in and show you those machines, show you the different probes. But as ever with equipment, you need to work out what you want to do with the equipment, and then choose the machine and the probe correctly for that.
Yeah, someone is asking, I'm just reading the questions, that when we are starting a neonatal program focusing on procedural, which machine brand equipment do you recommend? So again, I'm not in favor of any of them, but you know what I recommend, that for example the GE, you know, you can go down on the depth 2.5 centimeters, so that is really helpful in small babies, and that's the machine I personally prefer when I'm doing preemies. Of course, you need a linear probe, very high frequency linear probe for these purposes, and yes, and brand, it just depends. As I just said, the GE is the one that goes up to 0.5 centimeters. That's the one I would recommend.
Just to tack on to what everyone's been saying, I agree completely to get the reps out and really test out different machines and see what is going to be the most beneficial for your group. Our group decided before I got on board to use the same machines that our vascular access team had, because they wanted to focus mainly on vascular access. Even though at this point I do wish I had the ultra high frequency probes that I know GE has. But getting an idea of what you want to do with your program and testing out a bunch of different machines.
Yeah, I put one extra cat. I'm wondering, Stephanie, if you were talking about the Sonosite machines, which I think are tremendous for their linear probes. They do not have a sector probe with a small enough footprint and a high enough frequency to do cardiac imaging in our preterm babies, and I think that's a real shame. And we've checked in with the company about that. They don't have plans currently to release the kind of small footprint sector probe that we want. I just remember that I had this image on my computer. This is when I talk about the high frequency small footprint probe. This is the GE linear 10 to 22 megahertz probe. This is me scanning the tip of my index finger, and you can see here individual arteries and veins in the tip of the pulp of my index finger. And when I put pulse wave Doppler on that, you can see, and I'm very cheesy, you can see that my heart skipped a beat because I was so excited about the image quality of this probe. It's absolutely bananas.
And maybe that's the one that we have as well. It's a really nice machine. It's also great from infection control standpoint, just because it's a nice flat screen. And I like that skip a beat, Alan. I can imagine you doing that.
Yeah, we have that one too. Well, one of the ones we have is that. Yeah, it's that one.
I think everyone here would agree that if you're still in the initial stages of training or initial stages of your program, the handheld machines, though may look attractive and tacky, I think staying away from them if you have the budget for it, and getting a machine where you can have better quality images is one approach, especially in the initial stages. But once you have enough people trained who are able to use, who are able to interpret the images accurately, then going for the handheld devices may be a decent idea.
Also got a question coming through on the chat here about if we could talk a little bit more about sim-based trainers for the NICU. I know, Alan, you started talking about that earlier, but if we could delve into that a little bit more. I mean, I feel like everybody should have a Blue Phantom, right? Probably one of the pediatric Blue Phantoms. You can, I mean, there are lots of recipes online where you can make them yourself out of various things, ballistics gel, gelatin. I just don't know that those tend to last as long and aren't as refillable as a Blue Phantom. But other sim trainers that you guys like?
We have the Blue Phantoms as well. We also started using, even though they don't have as many pediatric applications as they do adult. A lot of the lung and vascular access and cardiac does go through. We have the SonoSim simulator that allows for virtual evaluation of cardiac and lung images.
Ellen, you were saying one of the Echo Sims can now use it for UVC lines, is that right?
Yeah, I really enjoy the EchoCom simulator. I feel like I'm just a rep today. Just a rep. Reps are awesome and an integral part of healthcare development. I do have a personal preference for the EchoCom Sim. This is their website, again, sharing on my screen. This is a device that was made by a pediatric cardiologist in Germany, who called Michael Weidenbach, who developed the concept in the neonate. They have taken a bunch of 3D ultrasound data sets from healthy babies and babies with structural congenital heart disease. They suspend those virtually inside the mannequin space, and then you use what looks like an ultrasound probe to scan through that. And it's a very good way then to develop that mechanical link between your hand movement and your eye and what happens on the screen. So that the first few times you do any kind of cardiac ultrasound, that you aren't worried by the baby wriggling and the nurse tatting and the parents getting upset. You know where you are and what you're looking for. There's no substitute for scanning actual babies. But again, some of the reasons why starting with PICS or umbilical lines is such a good place to start is that you've always got a baby on your NICU with a PIC or an umbilical line that you can ask the parents nicely to practice on. So this is the EchoCom. It's my personal preference, and yes, it now has UVC data sets in it where you can see the UVC entering the heart or not entering the heart. The team at UCLA has a fantastic neonatal echo simulator, which is more designed for hemodynamic measures. So if you want to use it and get facile with making measures of vessel size and stroke distance and things, I think that's absolutely worth looking at. The problem is that most of us don't have the budgets to individually have these. I happen to have an EchoCom that I have on loan that I can send out to people if they want to trial it. So feel free to email me, alan.groves@austin.utexas.edu, and we can set that up, shipping that out to other centers if they want to try it. I think some of the other simulators are quite good, again, for some of the basic applications. The vascular access simulators are pretty good, actually. So the standard blue gel one, I think, is about $600 and has a vessel size down to 2 millimeters. There is a manufacturer in Spain that has a vessel size down to 1 millimeter that I've ordered, but I haven't seen if that works or not. That's this morethansimulators.com company. So they have a vascular access simulator down to 1 millimeter.
Alan, have you used the BabyWorks? The BabyWorks one?
I've tried. It's really good, but they're still coming up with the softwares. You know, like when they came to talk, they didn't even have PDA yet. And now I think they do, and it looks really nice. It's quite expensive. The other one, I have the EchoCom, but the other one we have at CHOP is this one. It's called, oh, sorry, the CAE. It has an augmented reality. It's very fancy, and it's really, really very expensive. It's about $100,000, but it has echo, abdomen, and lung. And then it comes with these goggles, which, yeah, gives you this augmented reality. Very fancy. It's really cool. Yep.
We've gotten a few questions as far as what indications to start with. So in your opinion, what are the best indications to start when you're starting your program that only require the most basic level of training? And also, is it better to start with just one or two things, like confirming line placement and endotracheal tube positioning?
Yeah, I don't know who wants to go first. I don't want to speak all the time, but I'm going to be brief. I'm going to say again that you really have to identify what your needs are first of all, right? And start there. So of course, if you want to start with echocardiography, that's the one that's the most difficult. It's going to take a long time for you to get trained on that. But let's say, you know, people usually start with procedures because it's very, it's very nice. You really feel very good that you are, you know, getting all these procedures with probably one attempt and in a very safe way. But, you know, it doesn't matter if you have a maternity where you have all premature infants and you want to start with lung ultrasound to measure lung ultrasound score. And based on that, you know, this is surfactant or not. It's very easy to learn lung ultrasound, for example, but it just depends, again, what your needs are. Sorry, God, I want to let.
Is anybody having joy with ET tube position? I still really struggle with it.
Yeah, it can be a challenging one to get those views. We started off with the UV lines just because there were a lot in the unit. We initially started with the phased array and then really started moving more into linear, and it's not a bad way to start since there are a lot of lines there. And as Maki said, it depends on what you want. Bladder is one that people have started off with just to at least get ultrasound within the unit. The more you have ultrasound within there, then everyone gets used to seeing it. And then they start using it for more things. So bladder is also low-hanging fruit just to get your hands you know, with getting ultrasound in there.
I totally agree with Shazia. I mean, I think really what it is getting that hand-eye coordination and getting people familiar with using the probes and the machine, right? So I think incorporating it in as an adjunct to the tools that you already have into things that you already do is probably the easiest way to get folks accustomed to using the machine. So going for UVC placement, I think, is something that is super easy and accessible for people to do, right? Looking for free fluid, like Shazia said, bladders, like Maki said, lungs. I mean, just anything that really gets somebody to put a probe on a patient, I think is probably a good start.
And the beauty is with, so go ahead, sorry.
I was just going to add to the bladder and lung that neonatologists are trained to look at head ultrasounds even before they use ultrasound, as in we look at grade 1s, grade 2s regularly and talk about those on a regular basis with families. So to add to those, I would say maybe head ultrasounds would also be some of the first ones to access, like easier access, will get better with your knobology and getting comfortable with using the probe and the machine itself. So
something that might be interesting to do is flip that question on its end and say maybe what procedures or what indications are fraught with some sort of issues, say whether they're internal, whether they're technical, or whether, you know, it's interdivisional based. But for us, I would say that head ultrasounds are probably ones where especially our radiologists really don't want us to be doing head ultrasounds, because they can be very difficult to interpret, and they can be just a minute change in your probe position and you can have a whole different read. Our cardiologists really don't like us doing heart stuff, because yes, that is their territory, and no matter how much you remind them that this is not to replace their full echo, it's still an area where it can be controversial. So if you're having a hard time coming up with what indications you want to start with, maybe you could also flip it on its end and start with what indications you don't want to start with.
I think that's a really important message. I don't think head cranial ultrasound in the newborn satisfies the criteria for a POCUS indication unless you're looking for a midline shift. If you're looking for a midline shift and you think you'd get an MRI or a CT and a neurosurgical intervention, that's fair enough. I come from the European model where we did all of our own scans and interpreted all our own scans. I think that's totally fine, but it's not what people want to see happen in the US. Same for cardiology. There's too much risk. That, you know, the big indication for us for structural congenital heart disease is a cyanotic baby, and that cyanotic baby either has pulmonary persistent hypertension in the newborn or complex congenital heart disease, and the risk of missing total anomalous pulmonary venous return is too high. I know a bunch of very talented cardiologists who've missed that diagnosis. Neonatologists will invariably miss that diagnosis, so it's too risky. I'm keen to hear from the panel about pneumothorax. I've worked with a bunch of people that feel really comfortable to diagnose and intervene on a pneumothorax from point of care ultrasound. I haven't got there yet, but I'm keen to see where you guys are for that. Pleural effusion for me, very obvious. PICC lines, peripheral lines, umbilical lines. Start procedural. Diagnostic is the next level for me.
We've gotten a few questions as far as more extensive exposure past a 1 or 2 day workshop. Are there any programs, established programs that you guys know of that accept external providers in to rotate for more exposure in point of care ultrasound?
The bottleneck is people that are able to provide the actual hands-on skills. I think it's a huge problem at the minute. So I think most of us are so busy trying to train all of our own attendings, fellows, and nurse practitioners and nurses that to offer to train other people's as well is really challenging. We need, Mackie's trained 1,000 people on her courses, but we need to get a fair amount of people able to be present in person, scanning in actual babies. That's the bottleneck.
I think what's useful also is to see what within the hospital you can utilize. So we had an adult, there's adult POCUS fellowship, and so they had scanning shifts. So our fellows could sign up and potentially they're welcoming to us to be able to do scanning shifts for them. So there may be other mechanisms within the hospital itself that you can look at to see if there's other people that you can scan with that will do a lot of scanning.
Can you guys talk at all about the ONTPD curriculum that is being developed as far as other courses to get people's feet wet, other resources to share that come to your mind as far as being really helpful for providers who are starting POCUS programs?
The ONTPD curriculum that is being developed is on the NeoFlip platform. So it's really going to be more of a flipped classroom based curriculum. If you're talking about like active, getting your feet wet workshop style, I mean, I've gone to Maki's course twice. I liked it so much. But there's also the CHLA course for echocardiography for functional echo. I thought that was a fantastic course. So those are two that I would certainly really recommend in terms of workshops.
And as Maki had mentioned, we're really fortunate to have been able to partner with them at Stanford. The Stanford course will be in March as well. So there are other courses, and it sounds like maybe Alan's going to have one at some point too. So there are more courses popping up around, but really, which is great to get in there and, as Karina said, to go to a couple of them, but having some sort of standardized way to keep it going in the unit, it's what's going to be really useful and really be able to hone that in.
Just to add to the research sharing platform, TCAN has a chat group, which I think some of our panel members are also a part of the chat group. There you can ask questions, mostly simple questions that you can get quick answers to, share your documents, ask for other documents from other programs, established programs. That chat group has been reasonably active and it's easy to join, and usually the QR code to join the chat group is shared with our TCAN newsletter on a monthly basis. So.
Great, thank you guys. I know that we're a few minutes over, but we got several questions about billing, credentialing, storing images, and quality assurance. Again, this is the first, and more questions about training, of course, but this is the first session in more of a longitudinal webinar series, and we do plan on going over those topics in more details in some of the future webinars. I apologize if we weren't able to get to everybody's questions. There were a lot of amazing questions coming in. When we send a follow-up email, we will try to address a few of those as well as include some of the resources that were discussed during today's webinar. We have a survey here. If you click on the QR survey, just to give us a little bit of feedback as far as the webinar today, what worked and how we can improve on it for future sessions. Thank you everyone for attending. Thank you so much to our expert panel as well as our overall planning committee.
Thank you so much. Amazing session.
Thank you.